Good evening, Amandeep.
Hello, good evening, sir.
Good evening. We'll just wait for some time.
Yeah,
Huh?
sure. Yes, yes, sure, sir.
Yeah. Meanwhile, you can upload your presentation.
Yeah. The slides are seen, sir.
Yes, I can see the slides.
Okay, all right. As soon as you tell me, then we'll start, sir.
Okay. We'll just wait
Sir.
for some time, 5-7 minutes, and we'll start then.
Yes, yes. Okay, sir.
कैसे हैं मनदीप?
Hello, good evening, sir. Thank you so much.
Evening.
ठीक हो बिल्कुल. Hello. Sir, so there will be a case presentation after this, right? After the talk?
Yeah, after that, we have got two cases. Okay.
Oh, okay.
And so both will be like a short case only.
Short
Matlab,
case. Okay. All
yeah,
right.
yeah, yeah. And
So,
I'm waiting for even Dr. Ganesh Bakshi and all to join.
yes, yes, sir. Yes, yes.
Hi, Amandeep.
Hello,
Yes.
sir.
Good evening, Pankaj bhai, and good evening,
Good evening,
Ganesh.
sir.
Yes.
Amandeep, कैसा है? How was the day?
The day was long as usual, sir, but it's okay.
I know, I understand.
Yes.
तो दिल्ली दिल्ली आने वाला है नेक्स्ट वीक, स्किप कर रहा है.
Thanks. आऊंगा सर.
Okay. Saturday, Sunday.
Sir, Friday, Saturday. I'll go back on Saturday night. Friday evening, that is their presentation of whatever ongoing studies and
ठीक
all.
है. Okay. क्या करें? इसमें पैनल डिस्कशन कर रहा है आज.
नहीं सर, जैसे half an hour, 40-minute talk, and then they have two cases, so we'll just take those cases.
I
I'll just give
think
them an
mostly
overview.
this talk of yours will cover everything.
So, what will happen, Ganesh, with reference to that talk, then they will be, wiser enough to answer properly, na?
ठीक है, no problem.
And immediately, क्या
ये
होता है कि once that knowledge is there, very fresh in their mind,
हम्म
then when we discuss the cases, it will be very nice for them.
हम्म सर, ये मेटास्टैटिक प्रोस्टेट कैंसर में एक्चुअली यूरोलॉजी एग्जाम में क्या आता है? शॉर्ट नोट आता है, ड्रग आता है, क्या आता है? बिकॉज आई डोंट
Usually,
थिंक मेटास्टैटिक केस नहीं रखेंगे शायद एग्जाम में.
no, acute as a short case रखते हैं ना,
रखते हैं.
metastatic, yeah, they keep, because then the discussion will go on, na. Basically, see, chemotherapy is not very important in all the cases, but hormonal therapy and lots of research is going on. So even the examiner, even in the recent advances, trials, all these things, there is one table for that. Na? Recent advances, trials, whatever it is there. See, in DNB exam, it is very clear. When we are doing the case presentation, it is very clearly mentioned that you have to cover right up to the management, but we are not supposed to discuss about the recent advances or the trials which are going on. That is not,
ओके.
we are not supposed to ask in long case or short case. Very clearly mentioned, guidelines by DNB. So they have got a separate table for that. But in short case, they do present. We have last time we had that acute, spine problem. Patient had come. So that was a short case. If they
ओके.
get it, they keep it.
नहीं,
So
तो
I think,
आफ्टर Amandeep's presentation we'll take it as a short case only. It will be better. तो बच्चों को
so
वैसे
after,
उनको आदत पड़ेगी वैसे.
that is what I'm saying. These two cases will, so that, you know, I'll tell you very frankly, people now in the malignancy, every hospital is not doing all the surgeries. So there are so many hospitals where endourology is going on, other transplant. Many hospitals they are doing transplants, endourology. Onco is comparatively less in other hospitals. So the concept are also not very clear. So if like Amandeep, if he clears, like last clinic, you cleared so many concepts, and it was a very nice discussion. So like for a metastatic also, people will learn many things.
राइट
So
सर.
that will be helpful even in their practice also as well as in the exam.
नहीं, that is good.
In JJ we call BMR, that is basic में RADA. So Amandeep का talk के बाद में there are many basic things that
सर
students
ऐसा
will
बोलो मत.
understand.
जेजे का मैं भी हूँ, पंकज सर भी है और आप भी है, और
No,
ऐसे बोलो मत.
we used to say BMR is basic में. We used to tell if someone is not knowing, we say अरे यार तेरा तो BMR है. Like that means that basic should be clear. And this Amandeep will, I think, will clear everything about
यस
metastatic.
यस, एब्सोल्युटली मस्त है वो
Yeah,
प्रेजेंटेशन.
yeah. Okay then. Can we start now?
9-10 तो बच गए सर, चालू करते.
Yes, चालू कर. Amandeep, you can start. Huh?
All right, sir. All right. Okay, sir. So is the slide seen as full screen?
It is seen and
Okay.
voice is clear.
Okay. So good evening, everyone. I have been asked to speak about metastatic hormone-sensitive prostate cancer. So what I'll do is I'll go over some questions that come to our mind when such a patient comes to us, how we plan management for such a patient, what all do we investigate, what all options do we have, what are the components of treatment that we have. I'll try to clear your basics as to why are we doing what we are doing, because what we are doing can be read and learned, but if you understand why we are doing it, you will probably be able to learn it and remember it better. So I'll probably speak for about 40 minutes and then we'll have those two cases and probably also answer your questions as well. Okay, I'll try to answer as many questions as I can on my own. So let's start. So this is the first case that we have. So this is our usual patient as they come to us, 70-year-old male, ECOG 1. So whenever you're presenting an onco case, either as a short or a long case, be sure to mention the performance status of the patient to the examiner, okay? Because that is what decides how intensively you can treat this patient. This patient does not have any significant family history, which is very important to mention even in a short case in a patient who has metastatic prostate cancer, and no comorbid illnesses, again very important to mention. So even if it's a short case, these things should come, okay, because this will decide how much you would want to treat and what all you would want to treat with. Okay, so this patient had typically has some urinary complaints, had a catheter also 2 weeks back, and on the DRE that's a grade 3 hard nodular prostate, and we've done routine blood tests which are all okay, but the PSA has come out as 254. Okay, so now we need to biopsy. So we are thinking that the PSA is high, so this patient probably has prostate cancer, and because the PSA is so high, he probably has metastatic prostate cancer, right? But we need to prove it, so we need to do a biopsy. So where do we do the biopsy from? We typically do it usually from the prostate only. We need not aim for a 12-core biopsy or a systematic biopsy or a systematic plus targeted biopsy, because in such a patient in whom the PSA is in hundreds, the aim of the biopsy is to prove that yes, we are dealing with prostate cancer, and to find out the type of the prostate cancer that we are dealing with, whether there is something apart from the adenocancer prostate also. And so a few cores from each lobe would be enough. Sometimes in patients who have widely metastatic disease, if they've done their PET scan also and come to you before the biopsy, you can have a discussion of doing a biopsy from some other site, which would cause less pain to the patient and less chances of urinary infection. Okay. Now, we've been taught that we always should be thinking of an MRI prior to the biopsy, right? So in this patient, should we do the MRI prior to the biopsy? So you need to know why do we do the MRI prior to the biopsy. Okay. So if somebody has a raised PSA, and I'm talking about borderline raised PSA, not somebody with a PSA of 254. If somebody has a borderline raised PSA, you are suspecting that this patient probably has prostate cancer. Okay. So what do? We may want to repeat a PSA again after a course of antibiotics, check the urine routine, check the urine culture. But finally, we have somebody with a raised PSA. So we want to now investigate him further. So we want to probably biopsy, but we do an MRI prior to the biopsy. And there are certain things why we do it. One is the PSA may be falsely elevated because a lot of conditions lead to raised PSA. And if the MRI does not show a very suspicious lesion, we can have a discussion with the patient that we might want to forego the patient's biopsy. Okay. So typically, if there is no PIRADS 3, 4, 5, if it is only PIRADS 1 or 2 on the MRI, we may choose to not biopsy this patient. Okay. So the MRI will help to decide to not biopsy the patient. Now, if there are PIRADS 4 and 5 lesions, you would definitely want to biopsy such a patient. And then as per where the lesion is seen in the MRI, you can do targeted biopsies so that you target the lesion which is the most suspicious, so that you are most accurate in getting the Gleason score of the patient. Okay. And the third reason why we do an MRI is we get a picture of the T staging of the lesions, right? That whether they are localized, whether they're going extracapsular, and whether even the seminal vesicles are involved. And within the pelvis, we can even have a look at the nodes and even some bones. So that is how we look at the MRI. Okay. So before doing the biopsy, we would want an MRI in a patient with a borderline raised PSA, because we may get away without the biopsy, and we want to know where is the lesion so that we know where to do the biopsy from. These are the things why we do the MRI. Okay. Now in this patient who has a 254 PSA and your DRE is a grade 3 hard nodular prostate, if you do the MRI, you're not going to avoid the biopsy. And even if you do the MRI, it is not going to tell you where to take the biopsy from. And because it is probably widely metastatic because of the PSA in hundreds, you don't even want to know the local staging of this patient because you're not going to do local therapy for this patient, right? So then there is no reason to do an MRI in this patient. Okay, so this patient does not need an MRI prior to biopsy. But instead of 254, if the PSA was 25, now this is not borderline raised, but this is not very high also. So I'm not sure whether this is metastatic or not. I would do an MRI for this patient before proceeding to biopsy. Okay. Now, how many cores for this particular patient with the 254 PSA grade 3 hard nodular prostate? Just a few cores from either prostate lobe, just to prove cancer. Okay. So our patient has adenocarcinoma prostate with a Gleason score of 9, not surprising. Okay, so as I told you, the evidence for MRI prior to biopsy comes from these 4 studies, okay? And that is why the recommendation by the guidelines is to perform MRI before prostate biopsies. But the patients in these trials had borderline or marginally raised PSA up to 15, and very few had an abnormal DRE. So this patient of ours is not this trial wala patient, right? So these trials and this MRI before biopsy is for your early spectrum of prostate cancer. Okay. Now, so you have the PSA, you've done the biopsy, you know there is prostate cancer and aggressive prostate cancer. So now you want to do some staging investigation. So this is what we can do. We can either do a CT or a bone scan as per our guidelines, or a PSMA PET CT, right? The thing is, this has been discussed multiple times over various fora, but I think we should move away from this, and what your answer should be PSMA PET CT scan. Okay, because it is more sensitive, more specific, very easily available in our country, and the cost is also not too high. So your answer in the exam should be a PSMA PET CT scan. Okay. Now, what if the examiner asks you that the patient has already come to you with a CT and a bone scan done already? Then you can probably say that if the CT and the bone scan are showing widely metastatic disease, there is not much more information to be gained from a PSMA PET CT scan, and hence you would not do it. Now, another point of argument is PSMA PET CT scan is more sensitive than the CT and the bone scan, but at a PSA of 254, that difference in sensitivity is probably lost, because at a PSA of 254, even the bone scan would show you metastatic disease, right? So when the PSA is so high, if the examiner or somebody else is arguing with you कि इसको तो bone scan भी चलेगा, mets तो दिख ही जाएंगे, that is a very fair argument. Okay. Now, so we know this, that the PSMA PET CT scan is very, very sensitive, is very, very specific, and that is why you would want to have a PSMA PET CT scan if given a choice. Okay. Now, so what do the guidelines say? They say perform metastatic screening, including at least cross-sectional abdominopelvic imaging and a bone scan, and you can also do a PSMA PET CT. But you need to be aware that most of the trials have used the bone scan, and hence the treatment is influenced by what the bone scan tells us. But we treat as per what the PSMA PET scan tells us. Okay. Now, some patients might have an FDG PET CT. So why do we not do an FDG PET CT in prostate cancer? Because FDG, the tracer FDG, goes to cells which are rapidly dividing in the body. Rapidly dividing cells in the body, the glucose cycle is taking place very fast, so they take up FDG. Now, prostate cancer is not a very fast growing cancer, so the cells are not very rapidly dividing, so they don't take up FDG so well. And that is why we do not do FDG PET scans for our patient. We do PSMA PET scans because PSMA goes to that site where the prostate cancer is. Okay. So what if the patient has done an FDG PET scan and come to us? So now if that FDG PET CT is showing widely metastatic disease, probably choose to not repeat it. But if your FDG PET scan is not correlating with your biopsy and your PSA, I would probably want to have a PSMA PET scan for the patient. Okay. Now, as I told you, we would want to biopsy to also, one, prove cancer, and second, know the type of cancer. So as we have adenocarcinoma prostate with Gleason 9, some patients, especially those patients who have Gleason 9 and 10 disease, can have some neuroendocrine component also in their cancer. And it also happens that with time, with the treatments that we do, these 9 and 10 cancer patients turn into neuroendocrine components. Okay. But at baseline, the patients may have only adenocancer prostate or adeno plus neuroendocrine. If the biopsy does show a lot of neuroendocrine, then we might also consider doing an FDG PET CT for that patient, because in that patient, the PSMA PET CT may not light up too much. Okay. But you have to remember that PSMA PET CT is the first scan that you would want to do. Okay. Now, what if the PSA was 5.8 and the patient is a PSA non-secretor? So some patients, even if they have widely metastatic disease, if they have bone pain, if their Gleason is 9 or 10, their PSA may not be very high. Okay. So such patients are called PSA non-secretors. Around 5% to 10% maximum of our prostate cancer patients are PSA non-secretors. And in such patients also, we don't know whether doing a PSMA PET scan is better or an FDG PET scan is better or a bone scan is better. But still in these patients, we do a PSMA PET scan. Okay. Now, so how do we stratify our patients? So you need to remember that as soon as you realize that you are dealing with metastatic prostate cancer, you need to divide the patient into one of two categories. Okay. And that depends upon the volume of the disease. So the volume of the disease does matter. That is the volume of the disease that is seen on the scan. Okay. And what do we take into account? We take into account the number of bone mets. Why do we take into account only the number of bone mets? Because that definition of low volume versus high volume was given on the bone scan. It was not given on the PSMA PET scan. PSMA PET scan tells you about bone disease, tells you about visceral mets, lung, liver mets, and it also tells you about nodal mets. Okay. So in stratifying patients as low volume, high volume, we do not take into account the non-regional nodes. By what I mean to say that if there is patient A who has 3 bone mets and lots of nodal mets, supraclav nodes, mediastinal nodes, para-aortic nodes, and there is somebody else who has lots of maybe say 6 bone mets but no nodal mets, that 6 bone mets would be high volume disease, but this patient with 3 bone mets and lots of nodes would still, as definition gives it, be low volume disease. Okay, because we don't take into account nodal disease in stratifying patients as low volume or high volume. Try to not use the term oligometastatic prostate cancer, although you would want to imply that you're dealing with less mets. Try to use either low volume metastatic prostate cancer or high volume metastatic prostate cancer. Okay. And where does the definition come from? The definition comes from the CHARTED trial. What did this trial do? This trial used docetaxel along with androgen deprivation therapy, and it gave these definitions: low volume and high volume. Okay. So high volume means what? 4 or more bone mets, including 1 or more outside the vertebral column or the pelvis, which means the appendicular skeleton. Okay. Or you could have visceral mets. And now where are these visceral mets picked up? If you've done a PSMA PET scan, you would come to know whether there are mets in the lungs or the liver. If you've done the bone scan, see, bone scan itself is not complete metastatic staging. Along with bone scan, a CT scan needs to be done. That CT scan has to be chest, abdomen, pelvis. And in that CT scan, you would come to know whether the patient has visceral mets, which are lung or liver mets. If the patient has none of this, the patient has low volume metastatic prostate cancer. Okay. And again, these definitions come from CT plus bone scan, but we apply these definitions to PSMA PET scan in our routine practice. Okay, so do not get confused. It is PSMA PET scan only. Now, some questions. So if the patient has come to you already with the PSMA PET scan and there are florid mets on the PSMA PET scan, would you still biopsy such a patient? I mean, what is the point? The PSA is 500, PSMA PET scan पे seeing कि सब जगह mets है. Would you still biopsy? Yes, you would biopsy just to prove that there is cancer, to be medically legally safe that yes, there is cancer. And we've not yet reached a stage, where we start treating patients with chemotherapy, with those expensive drugs, heavy drugs, lot of toxic drugs, without proving that there is cancer. And we would also want to know if there is any coexisting neuroendocrine tumor along with that adenocancer of the prostate. Okay. Now we at TMH had this poster presented way back 7 years back in AUA 2018, where we said that the PSMA PET scan probably has the potential to replace biopsy. So this was the conclusion of our paper, that in patients with a high clinical suspicion of metastatic prostate cancer, which comes from the high PSA, a PSMA PET scan can be done prior to the biopsy. An unequivocal PSMA uptake in prostate and metastatic sites along with high PSA levels reliably confirms diagnosis of prostate cancer and hence has the potential to obviate the need of biopsy in this group of patients. Okay. But this has not changed our own practice in Tata Hospital also. We would biopsy all our patients who come to us with a very high PSA. Okay. But yes, with a very old frail patient, you can probably discuss with the family that biopsy nahi karenge to shayad chalega, kyunki treatment is not going to change much. Okay, so what does our patient have? So we've done the PET scan. The patient has PSMA expressing metastatic pelvic lymph nodes. Okay, so this patient is at least N1. Okay, there is only N0, N1, there is no N1, 2, 3. So N1, irrespective of how many nodes, irrespective of the size of nodes. And the patient also has PSMA expressing metastatic retroperitoneal lymph nodes. Okay, so this becomes M1A. Okay, our patient does not have bone mets. Okay, now just one word about the PSA level. Does a comparatively low PSA, should it worry you? So as I said, a PSA non-secretor. So if you have mets on the scan and your Gleason is 9, 10, but your PSA is maybe just 5 or 10, then this patient is a PSA non-secretor. This is a comparatively low PSA for the remaining clinical picture. We are not very sure in literature whether such patients do as well or worse than patients who have a high PSA. Intuitively, it feels like if the PSA is high, then your treatment would get the PSA down and those patients would do well. In such a patient whose PSA is 5, even if his PSA becomes 0 after 3 months of treatment, I'm not sure whether the quantum of treatment has actually taken place. Okay, so a comparatively low PSA does tell us that PSA might not be a very good marker for checking whether the disease is coming back in this patient or not. Okay, and I would definitely want my pathologist to look for something else in the prostate biopsy, especially if there is Gleason 9 and 10 over there, specifically to look for neuroendocrine cancer. And you would suspect that the patient has neuroendocrine cancer. So this bell should ring if you see these things in the patient, that the patient has only visceral mets. So prostate cancer, not very high PSA, lots of lung mets, lots of liver mets. Probably you're dealing with neuroendocrine cancer. Okay, multiple mets with no PSMA uptake. As I told you, FDG PET scan will show uptake in these mets, and rapid progression after initial response to ADT. So when you started ADT for these patients, which is androgen deprivation, the adenocancer part of the cancer responded. The neuroendocrine obviously did not respond, and you had rapid progression. So when these things happen, you need to suspect that you're probably dealing with something else than what your biopsy told you. Okay, now the first thing that we need to do for our patients is androgen deprivation therapy. Okay, so metastatic prostate cancer, the first thing that you need to do is get the testosterone down. Okay, now what are the options that we have? We have orchidectomy, we have our GnRH agonists, and we have our GnRH antagonists. How do we decide? We base our decision on a lot of patient factors, like the performance status of the patient, whether the patient can undergo that surgery even though we do it under local anesthesia, whether the patient is on blood thinners and we need to stop them for doing that surgery, whether the patient has a cardiac history, and we'll touch more about that, and obviously finances, because orchidectomy is a one-time expense to the patient and the family. Okay, and obviously some disease factors also. So if the patient has an impending cord compression, you would not want to give agonists because there's an initial flare. We will see all that again. And for somebody who has severe voiding LUTs, again, avoid agonists because you could end up putting this patient into urinary retention. Okay. Now, before we see each drug, let us see the androgen pathway. So this is what happens in the body. The hypothalamus secretes gonadotropin releasing hormone. That goes and acts on the pituitary. The pituitary releases FSH and LH. They go and act on the testis. Okay, specifically LH acts on the Leydig cells in the testis, and testosterone is produced. And the testosterone then goes and acts on the androgen receptor wherever prostate cancer cells are. Okay, so this is the pathway in the body. So how can we block? We can block each level. Okay, so GnRH antagonists. Okay, so GnRH release ही नहीं होगा from the hypothalamus. That is how we block it. GnRH agonists. So we give a lot of GnRH. Over time, FSH and LH का production decreases from the pituitary. That is how GnRH agonists work. Orchidectomy. So all these hormones get produced, but testosterone is not produced in the body because we've knocked the testis off. And even if testosterone is produced, if you block the testosterone receptor at the metastatic site, that is the use of anti-androgens. We will see all of this again. So the first thing is bilateral orchidectomy. So the rationale is that 95% of testosterone production in the body comes from the testis. So if you remove the testis, testosterone comes down. The advantage of the orchidectomy is it is the fastest way to reach castrate levels. Within 6 to 12 hours is where you can have castrate levels. So it is the most rapid onset of castration. It is very economical, just a one-time cost to the patient and family, and can be performed even under local anesthesia. The disadvantages is that it is permanent. So in some patients, so you must have heard that, if there is a concept of intermittent androgen deprivation therapy versus continuous androgen deprivation therapy. The dictum is that all patients with metastatic prostate cancer should get continuous androgen deprivation therapy. But androgen deprivation therapy does not come without side effects. So some patients are not able to take it for long. And some of those patients who don't have a lot of disease, we can consider giving them a holiday from androgen deprivation. Okay. But if done the orchidectomy, then you cannot give the patient the holiday. So a disadvantage of bilateral orchidectomy is that it is permanent castration and you cannot then do intermittent androgen deprivation in your patient who has less disease. And obviously, because we are operating, an occasional patient would have a wound infection, a scrotal hematoma, and some patients can have psychological issues. So in those patients, we can try subcapsular orchidectomy, which maintains the contour and some feel of the testis. What about GnRH agonists? So what is the mechanism of action? Sustained increase in the level of GnRH. So in the body, usually GnRH from the hypothalamus is given out as pulses. This pulsatile action goes and acts on the pituitary. But if there is a constant release of GnRH, then that pulsatile mechanism on the pituitary goes away and the pituitary finally stops producing FSH and LH. That is how GnRH agonists act. But because it is an initial sustained response, initially the pituitary will produce a lot of FSH LH, which will go and act on the testis and the testosterone will go up, which will cause an initial flare phenomenon. Okay, and which lasts for 15 to 20 days. And we need to cover this flare phenomenon, especially in our metastatic patients, because we don't want their disease to flare up. So how do we control more testosterone? But if we block the receptor, even if there is more testosterone, the testosterone won't act. And that is why we use bicalutamide, which is an anti-androgen. It will block the testosterone receptor. So even though there is a lot of testosterone in the body because of the flare, it won't cause a problem to the patient. And we give bicalutamide 50 mg once a day for 3 to 4 weeks. Okay, the duration for which the flare lasts. And castrate levels are achieved in 2 to 3 weeks after the flare has gone away. Now, various formulations are available in the market. These are the three main drugs that we have: leuprolide, triptorelin, goserelin. These are the dosages. Various routes can be used to give them depending upon which brand has produced them. And the annual cost is approximately 40 to 60,000 rupees, depending upon how frequently you want to give it. Okay, so these are GnRH agonists. Coming to GnRH antagonists, so we are stopping the release of GnRH from the hypothalamus itself. So suppression of the GnRH levels. So immediately LH and FSH will go down. There will not be any initial flare phenomenon. And the LH levels fall by 84% within the first 24 hours. And within the next 10 days, the patient is going to become castrate. So it is the fastest drug to make the patient castrate, but still it is slower than an orchidectomy. And the most common site with these injections is that injection site reactions are known, and these injections need to be given once a month. Okay, so the drug is Degarelix. It is given as a loading dose of 240 mg. So you get 2 vials of 120 mg. It is given subcute on the abdominal wall. So 120 here, 120 there, that is a loading dose. And then you give maintenance doses of 80 mg every month, subcute. Okay, so the annual cost, so this is the costliest androgen deprivation for the patient. Okay, but still much faster than the agonist and definitely avoids an orchidectomy for the patient. So recently, instead of using Degarelix, we have the oral antagonist, which is Relugolix. The Hero trial talked about Relugolix. That is the dose that we have, 360 mg on the first day. So 3 tablets on the first day, followed by 120 mg daily. So 1 tablet daily of 120 mg, or a 60 mg tablet, 2 tablets daily. And the approximate cost is not a lot. It is only 5,000 INR per month. So it is very much close to what our agonists would have, not Degarelix. Okay. Now, what about cardiovascular risk with agonists? As I told you, how do we decide what to choose between the two? We have patient factors, and one of the patient factor was cardiovascular risk. So agonists initially lead to an increase in LH and FSH, and the increased FSH has been postulated. These are all postulations, probabilities, nothing is definitely proven. Increased FSH has been postulated to lead to plaque rupture and cardiovascular events. This risk is especially high in patients who already have a history of cardiovascular events. Okay, so that is why in somebody who has cardiovascular history, ischemic heart disease, has had stenting, has had CABG, we would probably want to avoid agonist in this patient, either do the orchidectomy or do antagonist. Now you would say that because you're doing the orchidectomy, the testosterone is going away, so the FSH will go up. But the effect of orchidectomy on cardiovascular risk is not very well known, because we don't have our own studies about cardiovascular risk with orchidectomy from India, and orchidectomy is very rarely done in the West. So we really don't have data whether orchidectomy leads to higher cardiovascular risk. So this, we'll just see one paper. This was in 2014, about 10 years ago, but this was about in excess of 2000 patients. So what did they do? They gave some patients degarelix, which is the antagonist, which does not cause the initial flare, and they gave some patients agonist, okay, which causes the initial flare of FSH and LH, and they saw the cardiovascular morbidity. This is the conclusion. Men with no pre-existing cardiovascular disease at baseline, there is no difference in the incidence of cardiac events. But for men with pre-existing cardiovascular disease at baseline, significantly fewer cardiac events or deaths in patients receiving antagonists. So what do I do in the clinic? If the patient cannot afford any drug, the patient goes for an orchidectomy. If the patient does not want the orchidectomy and can afford some drug, then I look at the cardiovascular risk. If there is some cardiovascular risk, I talk to the patient about taking the most expensive drug, which is degarelix. If the patient cannot take it, then I do orchidectomy. If the patient has no cardiovascular risk, both options are given to the patient. Whichever drug they want, they can take. Are there any other options? Our patients cannot afford any drug. What can we do? So bicalutamide monotherapy has also been tried. So we use bicalutamide at 50 mg dose for covering the flare. As monotherapy, it is used at 150 mg dose. It was used in the past. It is not recommended now. Ketoconazole, Honovan, they have all been used and tried. But they do work also. But they are cheap drugs. So they have not been evaluated in trials for obvious reasons. So we don't have a lot of data available for them. So we don't use them. And most of our expensive drugs are also becoming cheaper with every passing month. Now, which modality of ADT? Okay, so if somebody has vertebral mets with impending cord compression, either the orchidectomy or the antagonist, because you want immediate androgen deprivation. Somebody has a large gland with severe voiding LUTs, again, immediate androgen deprivation. High risk of cardiovascular events, prefer antagonist over the others, but I've put a question mark because I'm not very sure. And if you have none of the above factors, please decide based upon what the patient and the family can afford, because ADT is just one modality of treatment. There is a lot more to come, many scans to come. Patients live long, lots of sequential treatments, so patients and the family need money. Okay, intermittent ADT, as I told you, some patients with less burden disease who have shown a great response to initial treatment, PSA has fallen to 0, and they start experiencing some side effects of androgen deprivation, you can probably consider giving them a break from androgen deprivation. For how long will you give the break? When will you restart androgen deprivation? What is the PSA when we restart androgen deprivation? Nobody knows. Okay. Do we need to cover with bicalutamide if you're switching from degarelix to agonists? No, because once you've given degarelix, the levels of FSH and LH in the body have gone down. So you don't need to cover with bicalutamide if you ever consider switching from the antagonist to the agonist for financial reasons. Any role for combined androgen blockade? So combined androgen blockade was ADT along with the bicalutamide. It is not done nowadays. So this term is obsolete. And how common are the hot flushes? So that is what I told you. Patients, if they have hot flushes, they might want to consider intermittent ADT, or you could give them these drugs. Megestrol acetate, they are all cheap drugs. SSRIs or pregabalin, these are all shown, they have all shown benefit in reducing these side effects of hot flushes, which not a lot of patients have, but if they do have, then it really gets bothersome to the patient. Okay, so our patient, just to revise, 71, no comorbid illnesses, PSA of 254, Gleason of 9, and low volume metastatic disease on the PET. Why low volume? Because even though he had so many nodes, he did not have a single bone met, and that is why he is low volume metastatic disease. Okay, so what did we do for the patient? We did a bilateral orchidectomy. Now, does treatment end there? So about a decade back, the treatment used to end there. Right now, the treatment does not end there, although sadly, we still do see a lot of patients in whom only ADT has been done. That is not correct. We need to do something for them. If something can be done based on the performance status and affordability, something more should be done, and that is add-on therapy. And we'll see what are the options that we have, and we'll also see how do we choose one of them. So these are the options that we have: abiraterone acetate, enzalutamide, apalutamide, and darolutamide. Okay, we'll just quickly see the mechanism of action of abiraterone. Okay, so this, don't look at the chart. This is just the way these steroid hormones get produced in the adrenal. Okay, so in the slide on antagonists and orchidectomy, I had told you that 95% of testosterone in the body comes from the testis. So where does the 5% come from? The remaining 5% comes from the adrenal. Okay, so we want to reduce even that 5% of testosterone. So we want to stop suppression of adrenal testosterone synthesis, and that is why abiraterone comes in. So abiraterone inhibits this enzyme. You need to know the enzyme's name at least for your exam. 17 alpha hydroxylase, okay, and also 1720 lyase. So when it inhibits these two enzymes, testosterone cannot be produced, as you can see, right? So the level of testosterone in the body goes further down. Okay, but because testosterone cannot be produced, and because the 17 alpha hydroxylase enzyme has also been blocked, the level of cortisol in the body also goes down, and that is why these patients need to be given prednisolone along with abiraterone acetate. Okay, and because cortisol also goes down and testosterone also goes down, all these precursors go up and aldosterone in the body goes up, which leads to the most common side effect seen with abiraterone, which is the side effect which we would see with hyperaldosteronism, which is salt and water retention and hypokalemia. So these patients get pedal edema, hyponatremia, hypokalemia. Okay. Okay, now what is enzalutamide? So enzalutamide, darolutamide, apalutamide, they are all androgen receptor blockers. Okay, so T is testosterone. Testosterone goes and binds to AR, which is the androgen receptor. Enzalutamide goes and blocks the androgen receptor. Same thing is done by darolutamide, same thing is done by apalutamide. They just have some minor things which are different between them. Darolutamide and apalutamide are probably the best tolerated, but they're also the most expensive as of today. Enzalutamide crosses the blood-brain barrier, and that is why it can lead to some cognitive disturbances, and you would want to avoid enzalutamide if the patient also has history of epilepsy. Darolutamide does not cross the blood-brain barrier and so does not have the side effect of the epilepsy and the cognitive disturbances. So that is why darolutamide scores over enzalutamide. One more side effect of abiraterone is that because we want to give prednisone along with the tablet, because the cortisol is going down, these patients can then land up with deranged sugars and other things that can go wrong with raised cortisol in the body because of the exogenous predni that we are giving to them. Okay, so these were our drugs. So this is one chart which compares all 4 drugs that we can give: Abi, Enza, apalutamide, darolutamide. Okay, doses are written, formulations are written. What you need to remember is abiraterone is taken on empty stomach. All others are taken either with food, without food is not very mandatory, but abiraterone needs to be taken empty stomach. Okay, and also just remember the dose of at least Abi and Enza. Now comparing these agents, so I have not spoken about docetaxel. When I was a resident, docetaxel was also an option, but docetaxel is no longer an option for our low volume patients. So our low volume metastatic prostate cancer patients should get androgen deprivation plus either abiraterone, enzalutamide, apalutamide, darolutamide, one of these 4. Docetaxel is not an option. Why? Because docetaxel is probably the most toxic of these, and we have data to show that the added benefit of docetaxel is not as much as the added benefit of giving ADT plus abiraterone or one of these drugs. Okay, so ADT plus docetaxel is no longer given for our low volume patients. But there is little to choose between the other drugs when it comes to their efficacy. They're all very, very efficacious drugs, and there is no clear evidence of superiority of one agent over the others, and there are also no trials comparing these agents, so there is no direct inter-agent comparison. Okay, so we've given ADT to our patients, and we've added one more drug to our patients, which is the add-on therapy for our low volume patient. Now, everywhere in the body there is a concept of oligometastatic, right? And our low volume patient is also oligometastatic, although I don't want you to use that term because that term is not used in prostate cancer literature. But as an oncologist, I would want to tell you that everywhere in the body, when we have oligometastatic disease, which means there is mets but not a lot of mets, usually we also want to do treatment of the primary, because that is where most of the disease came from. That is where most of the disease would even remain after the initial treatment has been done. And that is why we want to do some local therapy to the prostate, and we want to do radiation therapy to the prostate. Why radiation therapy? Because there is data for radiation therapy. From where? From level 1 trials. Which trials? HORAD trial and Stampede trial. Although HORAD trial did not show a lot of significant benefit, but it was tending towards benefit, and Stampede trial definitely showed significant benefit of giving radiation therapy to the prostate for low volume metastatic prostate cancer patients. Okay, so for low volume metastatic prostate cancer patients, you would want to start them off with ADT and a drug. Watch them for 3 to 6 months, because that will tell you how well they are doing and whether they are tolerating the side effects also of so many drugs that you are giving to them. And at 3 to 6 months, you do their PSA. Their PSA has hopefully fallen to single digits. In exceptionally responding patients, it's come to 0/1. And then we would want to treat the primary. Okay, and we treat it with radiation therapy to the prostate. Do we do it for all low volume patients? Yes, we consider it for all low volume patients. When do we do it? I just told you, at 3 to 6 months. Why do we wait for 3 to 6 months? Because we would want to treat the local disease only in those patients in whom the systemic disease has responded to treatment. So if your systemic disease itself has not shown great response to the treatment that you're doing, treating the primary is futile. Okay, so that is why you would probably want to biologically select your patients who are doing well with androgen deprivation therapy and then treat the prostate with radiation therapy. How much? You can probably go back and check the dose. I also don't remember now, but the dose is lesser than the dose that they use for primary therapy of the prostate. Okay, and the field, so they treat only the prostate. They do not treat the prostate and the pelvic nodes. Okay, so we expect that the pelvic nodes and other nodes in the body would show response to the androgen deprivation therapy and the additional drug that you've added. Why do we not do surgery? So we can do surgery. Technically, we can do it. A lot of people do it. And because a lot of people do it, there's a lot of evidence also. So we have a lot of case series, and the outcomes in those case series are good, but they are case series and they are not randomized control trials. And that is why the level of evidence for doing prostatectomy, which is actually cytoreductive prostatectomy, because you're dealing with metastatic disease, the evidence for cytoreductive prostatectomy is not as high as the evidence for giving radiation therapy to the prostate in a low volume metastatic prostate cancer patient. Okay, so there is no level 1 evidence, but numerous case series. Is it equivalent to RT? Every surgeon would tell you yes, but we've not yet found a way to prove it. But you probably can have a discussion with the patient that in somebody who has a large gland and if somebody has proper voiding LUTs, giving radiation therapy would probably worsen the LUTs. So you have two options: either do the prostatectomy, which takes care of the local therapy also that you want to do for the cancer and also gets rid of LUTs, or if you want to go only as per guidelines and want to give only radiation therapy to the patient, you might have to do a channel TURP for this patient to help him with his voiding LUTs. Okay. Now, do we also give RT to the metastatic sites? So this evidence is only in CRPC. It is not there in HSPC. So HSPC means what? Your initial metastatic prostate cancer patient. So your patient's disease is still responsive to androgen deprivation therapy. A CRPC patient is no longer responsive to androgen deprivation therapy, and that is where we use radiation therapy to the metastatic site. So we might want to give radiation therapy to 1 or 2 bone lesions, okay, or in oligorecurrent prostate cancer, but not in your de novo metastatic HSPC patient. Okay, no study has shown oncological benefits, so we don't do it. Okay, so we gave ADD to our patient. We added one more drug out of those 4 options that we had, and we have also planned that at 3 to 6 months we will assess response and think of local therapy, mostly radiation therapy, but in a select few patients surgery can also be offered. What more do we need to do? We need to look at bone health of our patients. Why? A, our patients are old, so they already have osteopenia, osteoporosis. B, our patients have bone mets mostly, so that is eating up their bones. C, we are causing androgen deprivation. We are reducing testosterone in their body. Testosterone suppression itself causes osteoporosis. So we are inducing more osteoporosis in the patient. So we need to look at their bone health. So what do? We give them calcium and vitamin D supplements. Do we do it for all patients? Yes. Every single patient who needs to start long-term androgen deprivation therapy should get calcium and vitamin D supplements as per guidelines. Okay. What more? Do they need that zoledronic acid, denosumab? That depends on the DEXA scan. Okay. So what is the DEXA scan? Again, as per guidelines, any patient who is starting long-term androgen deprivation therapy should have a bone DEXA scan. The DEXA scan gives us the bone health of the patient. It tells us whether the patient already has existing osteopenia, osteoporosis, or whether the bone health is good. If the bone health is good as per the report, this patient only needs calcium and vitamin D supplements. If the patient's bone health is not good, even before starting treatment, then this patient also needs zoledronic acid or denosumab. We'll see that ahead. Okay, so that is why we need to do the DEXA scan for our patients. So calcium is given this way, vitamin D is given this way. That is how we give it for all our patients. What about zoledronic acid? So it inhibits osteoclast function, so it prevents eating up of bones. For osteoporosis in HSPC, okay, so our patients are HSPC because they are newly diagnosed metastatic prostate cancer patients and they have osteoporosis. ये कैसे पता चला? DEXA scan किया है, इसलिए पता चला है. ठीक है? For such patients, 5 mg in a 100 cc infusion once a year, not monthly, not 3 monthly, not yearly. The dose is not 4 mg also. The dose is 5 mg once a year. Okay. For CRPC, which means the later stage of disease when the disease is no longer hormone responsive, that time it is given 4 mg once a month. Some studies also say giving it every 3 months is also fine. How long do you give it? Not clear, but probably up to 2 years. A dental checkup is mandatory before prescribing the patient zoledronic acid because osteonecrosis of the jaw is a described complication. It's an extremely rare complication, but it's an extremely problematic complication if it happens. So a dental checkup is mandatory. And you check your renal functions and you give it as a slow infusion because zoledronic acid is nephrotoxic, and also watch for hypocalcemia. Another option is subcute denosumab, 60 mg once every 6 months. Denosumab is expensive. That is the only difference. Now, what more advice to our patients? We need to tell them to do weight bearing exercises because we want them to maintain their muscle and bone health. So 3 to 4 times a week for 30 to 40 minutes. All this sounds very good on the slide and when I'm talking to you, but it is very difficult to ask our general metastatic old prostate cancer patient walking to the OPD कि आप हफ्ते में 3 बार जाके gym करो. But if possible, karo. Smoking cessation for any other patient that you treat, and reduce alcohol intake is also what guidelines say. Okay, so that was low volume disease. This is just one more scan that I'm showing you, and as you will see in this PSMA PET scan, lots of bones are lighting up. Okay, that liver is normal, but lots of bones are lighting up. Okay, so this patient has high volume disease. Okay, so high volume disease. What is the meaning of high volume disease? More than 4 bone mets, 1 or more met outside the axial skeleton, or you have visceral mets. Visceral means lung liver mets. Okay. Now, if your patient is high volume, how does the management change? Because it is high volume disease, you want to do something more, right? You want to do something more than just what you are doing for low volume disease. So what is doublet or triplet? So what is doublet? Doublet means ADT plus something. So we are doing doublet therapy for our low volume patients. Our high volume patients, as per the PEACE 1 trial, we should be getting triplet therapy. And then what is that third agent in the triplet? That third agent is docetaxel. Okay. So as per guidelines, if your high volume metastatic prostate cancer patient is fit to take triplet therapy, that patient should get triplet therapy. And then what are our triplet options? So ADT will be there, that chemotherapy docetaxel will be there. Now you have to add that drug. Okay, so it can either be abiraterone, which was used in the PEACE 1 trial, or it can be darolutamide, which was used in the Aramis trial, if I am correct, and or it can also be enzalutamide. We do not have data to say that apalutamide can also be one of the components of the triplet. Okay, but they are all similar drugs, so in clinic you can use them. Now, why did I say that your patient should be fit to take them? Because you're giving a lot of treatment to your patient. You need to see whether the patient will even tolerate it. So a lot of patients with metastatic high volume disease, they are already anorexic, cachexic, giving so much treatment, they may not be able to tolerate it. So tolerance needs to be checked. Okay. So that is the only change that happens in high volume disease. Doublet becomes triplet if the patient can tolerate. And now because you're dealing with widespread disease, there is really no role of treating the local tumor. Okay. So there is no role of RT to the prostate or cytoreductive prostatectomy in patients with high volume metastatic prostate cancer. Okay. Now our patient was a routine patient who had just come with LUTS to the OPD with a catheter. Imagine your patient comes on a stretcher. Okay. Why has he come on the stretcher? Because he cannot walk. Now, what you should see in that patient is, why can't the patient walk? Is it because of bone pain or is it actual loss of power? Now, how do you come to know that? Ask the patient to move his toes. If the toes are moving and if some movement can happen in the limbs, no, the power is mostly there, and it's just because of bone pain, hip pain, back pain that the patient is not able to move. But even if even if those small fine movements cannot happen, you are probably dealing with loss of power, and that is actually an emergency situation if the history is of short duration. Now, if the family tells you कि एक हफ्ते से पैर नहीं उठ रहा है, they've probably come too late to you. But if the history is about a few hours or maybe a day, then that power of that patient can probably still be salvaged. That is why duration of symptoms is very important. What is the management? So if that duration is such that you can still salvage that power for that patient, immediately that patient needs to get DEXA, 8 mg or 10 mg. You need to ask your orthopedic and neurosurgery colleagues, get an MRI spine done, start androgen deprivation immediately. You cannot obviously give agonist. If you have a biopsy which says there is prostate cancer hai, you can probably do the orchidectomy if the patient is fit for it. Or if the family is affording, give a shot of degarelix, because that is the fastest way to get the testosterone down. Okay, and explain the family guarded prognosis about limb recovery, because whatever we might do, the power may not come back to 5/5. Okay. Now in our patient, what about the catheter? So do alpha blockers work in those cancerous prostates? They work in those benign prostates because they relax the bladder neck. But in those cancerous prostates, which are large glands, they've probably eaten up into the bladder neck also, alpha blockers may not work a lot, but we still need to try them. Okay. Do you need to add a dutasteride to this patient? So you'll give silodosin. Do you need to give silodol D to the patient? Probably no, because what does dutasteride do? Dutasteride prevents conversion of testosterone to dihydrotestosterone, if I'm correct. But abhi body mein testosterone hi nahi hai, because you've done androgen deprivation. So there is nothing for dutasteride to act on. So there is really no role. If you add nothing, kuch hoga nahi, but there is really no role of adding dutasteride to this patient. Okay. And when would you give a voiding trial to this patient? We would probably allow these alpha blockers and even the androgen deprivation, which will cause shrinking of the prostate, to work for about 3 to 4 weeks, and then give a voiding trial to this patient. Okay. Leave that last thing. Now, our patient, so we need to look at the patient holistically, not just at the prostate, right? So our patients might have raised creat, so then we might do a USG to see if there is HUN, and if there is HUN, it probably suggests that there is a block down there. So if there is a unilateral or bilateral block, we probably do a PCN. These PCNs can create a problem because they are tubes during chemotherapy. Now our patients also might have hematuria because of the disease there. So what do we do for the hematuria? Does ADT work? Yes, it works, but it is going to take a lot of time to work. So you cannot say, okay, we've given degarelix, now keep the patient on irrigation and the hematuria will stop. So that does not work. It will work over long term. You might want to go in and do a clot evacuation, and at that same time do a channel TRP for the patient. If all that has already been done and tried once, twice before, and there are no clots inside, but the patient is still having hematuria, you can consider asking the radiation oncology colleagues for giving them hemostatic RT. It takes about 24 to 48 hours to kick in, but it is very effective. And finally, if all that has been tried and still not working, what you can try is angioembolization. Okay, so we need to then ask our interventional radiologists. So this is actually the way we think about managing gross hematuria in our patients. Okay, so mostly it is clot evacuation and then a channel TUR and fulgurating those bleeders here and there. But if all that has been done multiple times, then you need to start thinking about hemostatic RT and angioembolization, especially if there are no clots inside. If there are clots, you always have to go in and take them out. For pain at metastatic sites, so when you start androgen deprivation, that pain will go down. You will also give some painkillers so the pain will go down. But if it's still not going down, then we can give palliative radiation therapy to that metastatic site, not with the intent of treating the cancer, but with the intent of reducing pain for our patients. You also need to counsel them about prognosis. Your family is going to ask you, how long will the patient live? So, prostate cancer metastatic is not as bad as other metastatic cancers in the body. It is not as bad as metastatic bladder cancer, in which patients live only a few months. But you need to tell the patients and the family that the patient will mostly make it to a couple of years. but we will be able to tell better once the treatment has been started and we've seen the initial response. And do we have any indicators and can we predict the response? So yes, the first predictor is the volume of the disease, right? So our low volume patients will definitely almost always do better than our high volume patients, okay? And the second thing is the PSA response, okay? So we start androgen deprivation therapy and then we see the patient's PSA as per this study at 7 months after starting androgen deprivation therapy. And as you can see, the lower the PSA, so the greater the fall in the PSA, the more nadir the PSA, the longer the patient lives, okay? And this was only with ADT. Now we are adding ADT plus ABI, DOSI, all those things, so our patients may even live longer. Now, coming to one point, genetic evaluation. Do we need to do genetic evaluation for our metastatic prostate cancer patients as per guidelines? Yes, all metastatic prostate cancer patients should get genetic evaluation done. Okay, what are we looking for? We are looking for some mutations. Which mutations? 4 genes mainly: BRCA1, BRCA2, ATM, E10. Okay, why these 4 genes only? And why are we doing the genetic evaluation? We are doing the genetic evaluation because we have a drug with us, which is olaparib. Okay, what does that drug do? That drug works in some patients, works better, I would say, works better in some patients who have a genetic mutation. That is why we want to find out those patients who have the genetic mutation, so that later on in their disease course, not as first line therapy, but as second, third line therapy, we may want to use that drug in that patient if he has that mutation. That is what we are looking for. So we are looking for one of those 4 mutations. Where to get it done, what panel to select, and the cost. Okay, so if you are doing a basic 10-15 gene mutation, the cost would be around 15 to 20,000. You don't need to do the complete NGS for the patient or the complete genomic workup for the patient, because even if some particular gene comes back positive, which is not one of these 4 genes, there is really nothing that you will do for the patient. Okay, or you can tell the lab that these are the 4 genes that you want to get checked, and the cost will come down even further. Usually this is done by the MedGenome lab in Bangalore. Okay, implications for management, as I told you, find out if that patient has one of these 4 mutations, so that you know that yes, for this patient, this olaparib drug can be used later on. Okay, now why do you want to do the genetic evaluation right now? Because that genetic evaluation would be done on the biopsy sample, and the fresh biopsy sample, fresh disease from the patient which has not undergone any treatment, is the best sample for doing the genetic evaluation. Okay, if you have not done it at baseline, then what? Then once you have exhausted the first line therapy and the second line therapy, and now you want to see whether olaparib isme de sakte hain kya, then you can probably do the genetic testing. Then how will you do it? Then you will probably biopsy some metastatic site and send it for genetic evaluation. Okay, you would also want to do genetic evaluations in all patients who have a positive family history, irrespective of whether the patient has metastatic prostate cancer. Okay, we'll just take a minute to read what is strong family history. A strong family history of prostate cancer means brother or father or multiple family members diagnosed with prostate cancer, not Gleason 6, okay, something higher than that, at less than 60 years of age, or who die from prostate cancer. Okay, so my father had prostate cancer when he was 80. That is not strong family history. That relative also needs to have prostate cancer at an early age, which means that that cancer was genetically driven, and that is why this patient's cancer can also be genetically driven. Okay, or you can have multiple relatives in the family who have multiple cancers, so then you are probably thinking, there's a lot of cancer in the family, so let's check this patient. Okay, so why do we do genetic testing? As I told you, 1 out of 8 men has a mutation. This number is not so high in Indian literature, but that is what the Western literature is. Okay, and what are the genes that we want to check for? ATM, BRCA1, BRCA2, and PTEN, mainly these genes. Now, what is germline testing and what is somatic testing? I'll just tell you in 1 minute. So somatic mutation means what? The mutation is only in the prostate. That is where the cancer started. Okay, germline means what? This patient ka all cells in the body have that mutation. Okay, so to check somatic mutation, you have to check it on the prostate biopsy or a biopsy from any metastatic site. You need tissue जिसमें cancer है. For germline testing, it is a blood test. So blood में check करना है कि वो mutation है कि नहीं. Okay, now, so we always do somatic mutation checking first. Okay, and if the somatic mutation is negative, then obviously you cannot have germline mutation. But if so you first do somatic. If that is negative, that is the end of the story for this patient as regards to genetic evaluation. But if the somatic mutation is positive, then you would want to do germline testing for this patient. Now, why would you want to do germline testing for the patient? Once you have found कि इसको तो mutation है, so इसको mutation है, which you came to know from the somatic testing, will have implication for this particular patient. You would want to use olaparib later on. You would want to do the germline testing to see whether the rest of the family is also at risk. Okay, so germline testing in that patient, if that is also positive, it means that this gene is running in the family, and then you would want to screen other family members. So that is about somatic mutation and germline mutation and why we want to test and what we test and when do we test. Okay. Now, some scenarios, our patient is 90 years old. What would you want to do? Watchful waiting is the best thing that you can do for your patients. Just give them symptomatic benefit. Unless your 90-year-old is somebody who's walking, running, and then you would want to treat as per any other patient. ADT alone can also be used. It is not a bad choice. Okay, how do we follow up these patients? So usually follow them up every 3 months. How? We do a PSA. Only PSA. Every 3 months, only PSA. Routine physical examination. Our urinary examination as we would do as urologists, and also they are on some drugs, right? So the physician or the medical oncologist needs to check them for drug related toxicity. Okay, and for the disease, what is the trigger for a PET? When would you want to do a PET? Would you do a PET only when the PSA goes up? No, ideally you should do a PET once a year even if the PSA is low. Why? Because you want to see whether the disease is progressing, whether your patient is becoming CRPC, castrate resistant prostate cancer. And what is the definition of CRPC? Either clinical progression, which means the patient has symptoms, or biochemical progression, which means the PSA has gone up, or radiological progression, which means nothing of this has happened, but there is disease on the scan. Even that would be CRPC. So we should be doing a scan at least once a year, even if our patient's PSA is not rising. Okay. And what is the usual time for a patient to become CRPC? 1.5 to 2 years is kind of the rough estimate that you can give the patient and the family. That is the average time that patients usually become CRPC. That is that PSA starts to go up. So to summarize, biopsy, yes, we would do biopsy in all our patients. And then we would stratify our patients as low volume or high volume as per the PET. We would counsel our family and the patient with treatment plan and the likely prognosis. You start the patient on ADT. We decided how to choose between agonists, antagonists, and the orchidectomy. And then we give add-on therapy. And what is the add-on therapy? Not docetaxel if it is low volume patient, one of those 4 drugs. And you would add docetaxel if you want to do triplet therapy for your high volume patients. Okay. And you give RT to the prostate for low volume patients. You give bone health agents to all. You do DEXA scan and then decide about zoledronic acid. You manage the catheter because you're a urologist, give alpha blockers, channel TURP, manage the hematuria and the pain. Paraparesis, patient on stretcher is an emergency, especially if the duration of the symptoms is not a lot of days. And I've told you what to do about genetic testing. All right. So that was about initial management of a metastatic hormone sensitive prostate cancer patient. There is a lot more that we can speak about. We can speak about olaparib, cabazitaxel, lutetium, but these are all as second line, third line, fourth line therapies. We usually do not reach there when we are giving our exam, and this is probably enough to answer a routine viva about a metastatic prostate cancer case, and more so to be able to manage a metastatic hormone sensitive prostate cancer patient when the patient comes to you. Usually when the patient has become CRPC, this is mostly a medical oncology driven patient, and you should probably not be managing such a patient. Okay, so thank you.
Thank you, Amandeep. Fantastic presentation and really, enlightening us totally. So I think now we should go ahead with the case. I will request Brijesh, can you
Yes,
start
sir.
the case? And
Yes,
who is
sir.
answering today?
Sir, Dr. Hamid and Sabah.
Hamid and
Dr. Aisha, Dr. Swastik and Dr. Hamid.
okay. Fine. Ganesh bhai, you are there.
So let's start, sir.
Yeah, sure.
Yes, please start.
So 67-year-old male came with a complaint of nocturia poor stream and incomplete voiding with increased frequency and low grade back pain.
So I would like
Okay,
to
first
elaborate the
thing,
symptoms. Yes, sir. So I would like to elaborate the
yeah,
urinary
start.
tract symptoms first. Yes, sir. Yes, I would like to know about the frequency, urgency, nocturia, poor flow intermittency, and stream and sense of incomplete voiding, and also about his bothersome score and whether the patient is sexually active or not. Regarding the lower back pain, the site, onset, character, radiation, any associated symptoms like pain or fever, and sir, any aggravating or relieving factors, sir. Yes, sir. And sir, also I would like to know about the history of any pain, fever, any history of hematuria in past, any history of instrumentation, any history of weight loss, any history of weight loss, any history of breathlessness or pedal edema. Yes, sir. Any history of anorexia also, sir. In this case, sir.
Okay. Gaurang sir, do they
Any
also get it
comorbidities?
as a long case? I mean, does the history have to be so long and elaborative, like a long case? I'm just asking if
No,
it is, if
not
they
in
get, then
this
it is
case.
great. Ah,
Yeah, you can just go ahead. We are not interested in history nowadays. I mean, in this case.
okay.
So we will just
Okay.
skip whatever it is there. Unless and until you want to tell them that any particular history.
Yeah. So basically, in history, I mean, by the time you have finished examining your patient, you would know you're dealing with metastatic and you would want to present your patient that way to the examiners. So bring out those points that I told you when I was presenting the case, that's all. Okay? All this elaborate history, fine. If you get a long case by chance, definitely go over it. But if it's a short case, then just omit all this. Okay?
Yes.
Yeah. Let's skip this and let's go ahead.
I would have to examine
Okay.
the patient, sir.
So
Okay. Fine. All okay. You have examined. Did you find anything in the examination? Okay. You find something in DRE.
General examination, Bridges. Any back
Hmm.
general examination.
yeah,
So in local
Bridges, just
examination,
tell
sir.
us the positive finding.
Yes, sir. He just had in lower back pain with mild tenderness over thoracolumbar spines. No
Okay.
any palpable mass
Bilateral
or
test
lump,
is
no any
normal, sir.
visible
All of it is normal. DRE, abdomen, abdomen. Prostate grade 3 enlargement, hard inconsistency with palpable nodules in both lobes. It is non-tender and median sulcus is obliterated. Sir. Rectal mucosa is mobile and rectum is empty. No blood on gloves. Anal tone normal and fissures of fistula not there, sir. So there is a prostate grade 3 enlargement, sir. Hard inconsistency with bilaterally palpable nodules, sir. The median sulcus is obliterated and patient has a history of lower back pain and lower tract symptoms, sir. So,
All right. So can we
so most
summarize?
likely diagnosed. Yes, sir.
Yeah.
The patient, a 68-year male patient presented with complaints of lower tract symptoms with lower back pain. On examinations, the positive findings are grade 3 enlarged prostate, which is hard
We have an
inconsistency
elderly male with LUTS and back pain,
back pain. Yes, sir.
and we found
Tenderness
that
over
he has a
thoracic
hard enlarged prostate and some
prostate
tenderness on
with
the back.
tenderness over back over the spine, thoracolumbar
So
spine.
what are you trying? What are you thinking in terms of?
So most likely diagnosis in this case is a bladder outlet obstruction due to enlarged prostate, most likely malignant cause.
Perfect.
Prostate.
Okay, all right. So how do we proceed? What do we do?
So I would like to do I would like to perform CBC, renal function test, and PSA in this patient, sir, along with urine gluten microscopy, uniformity, and USG abdomen, sir.
Okay.
Abdomen plus pelvis.
All right. Okay. So your raised PSA is probably pointing towards a diagnosis,
Yes.
but I mean your patient also has LUTS. Does he have a
Yes, sir.
catheter? I don't remember, but
No, sir, no catheter.
but he has
Patient has-
LUTS. But the PSA
Yes.
is still very high, right?
Yes, sir,
47.4.
47. Yes, sir. Yes,
Yeah.
sir.
So
And
it's
hard
always,
nodular.
yeah, hard nodular also. Okay. So even if the PSA was 2 for this patient, you would think of prostate cancer because you have found
Yes.
hard nodular gland on your DRE, right? So it's
Yes.
always good to even send urine routine culture for your patients. Okay.
Yes. Yes, sir.
Okay. All right. What is next? Okay. So you've done the urine tests. All right.
Yes.
Okay. All right.
Sir.
Okay. So we know that PSA rise is not a false rise, it's a proper rise. Okay.
Yes, sir.
Because the PSA rise now is just 40, it's not 400. If it was 400, I would not be talking about urine routine and culture. Okay.
Yes.
Yeah, because we have still not reached a point where it is metastatic. It is just somebody who has LUTs, who has a hard nodular prostate, and we are just trying to evaluate this patient. Okay. So the PSA is 47 and we trust that PSA because our urine culture is negative. Okay.
Yes, sir. Yes,
What
sir.
next? Now what? Now you have somebody with a hard nodular prostate with a PSA of 47. What do you want to do?
Sir, I've also asked for ultrasonography of down pelvis and uroflowmetry. With this, I would like to do an MP-MRI of prostate, so multivariable prostate MRI, sir, to find out
Okay.
the locus. Yes, sir.
Acha, what purpose is the MRI serving in your patient?
So it's a hard nodular prostate, sir, with a PSA of
Okay.
44, sir. So I
Okay.
would like to know the local staging of. I would like to first know whether there are any pyrites positive or pyrites 4 or 5 lesion in the prostate, and along with any involvement of the seminal-vesicle or any local stagings for local staging also, sir.
Okay. So if I tell you that there are no pyrites 4 and 5 lesions on your MRI report, then would you not biopsy this patient?
Sir, yes, sir. I will biopsy, sir, because there are hard nodules.
Yeah. So what are the 3 things that I told you? Why do we do the MRI? One, to avoid the biopsy.
Yes,
In
sir.
this patient, can you avoid the biopsy?
No, sir.
No. Second, to know where to do the biopsy from, right? Do you need
Yes,
to
sir.
know from the MRI in your
No, sir.
patient
Hard
has
nodules.
nodules everywhere, right?
Yes,
Okay. So then what is the third thing left? To know local staging, right?
sir. Yes, sir.
Yeah. So now because your PSA is not in hundreds, your patient may not be metastatic, right? In which you would want to think about local treatment to the patient. So you would want local staging. So in this patient, if you want an MRI and if you give me this justification, I'm okay with you wanting the MRI. Okay, that your PSA is not straight off metastatic PSA. Some patients, because he has a grade 3 prostate, his PSA can be high with not a lot of metastatic disease. Okay, but
Yes.
don't say that I want to see some pyrids 4 and 5 in the
Yes, sir.
MRI.
Yes,
I want
yes,
to see where the lesions are. Okay, that is
Yes.
not why you are doing the MRI.
Yes.
All right, got it?
Yes, only for local staging.
Yes.
Because the people are very high. Yes.
Because the PSA is high, but he has a grade 3 prostate, so this PSA is not very high also.
Yes, sir.
Okay.
Yes.
All right. Then, so you've done your MRI. It has given you some lesions which are there. Do we have the MRI? Okay. So prostatomegaly 44 cc, median lobe hypertrophy, pyrids 4, SVs. Okay. So what all? Let's just quickly see what all do you look at in the MRI. Just some point.
Prostate volume, sir. Index lesion, size of the index lesion.
Why do you
and
see the
pyrites
prostate
lesion.
volume? Why do you see the prostate volume?
Sir, the size of the prostate, sir.
क्या करेगा साइज 45 है कि साइज 60 है कि साइज 25 है? Not in this patient. In any patient, MRI
Sir,
that you have.
Radiotherapy, in case of patients having lower intact symptoms with a large prostate, sir. If we plan for if it is a localized disease, sir, or locally advanced disease, sir, if we are planning for a radiotherapy, or in that case, sir, we might need to do
अभी तो पता ही नहीं चला है कि कैंसर है, राइट? अभी तो बस MRI किया है ना?
Yes, sir.
Right. You've heard of PSA density?
Not in this case, sir. No, PSA density was not done, sir.
I told you not in this case, right? But
Yes.
you're looking at prostate volume in the MRI. Calculate
Yes,
PSA
sir.
density. Why? Why do you calculate PSA density?
So in cases of any co-focal cases, sir, we might need to do a PSA density to.
Right. And what is equivocal on the MRI? What is it called specifically? Pyrids 3.
Pyrids 3. Pyrids 3.
If you have pyrids 3 and your PSA density is more than 0.15,
yes, sir.
then you do biopsy your patient as per guidelines, right?
Yes, sir.
So that is why prostate volume is important in the MRI. Okay. Whatever else you said, no, that
Yes.
big gland hai, to, no radiation therapy surgery, all that is also taken. But the first thing is this, because you have not yet gone to your biopsy, right?
Yes.
Okay. So you've seen the prostate volume, you've had a mental note of PSA density made. Then what else are you looking at?
So I would like to, I would know about the index lesion, sir. The pyrids 4 lesion is there. The pyrite staging is there, sir. Infiltration of any infiltration of seminal vesicles, extracapsular extension, sir. Any involvement of the rectum or involvement of bladder wall. Then, sir, local pelvic lymph nodes also, sir. Make a note of pelvic lymph nodes.
All right. So you have your T staging and some
Yes.
element of your N staging also done with the MRI. Okay. All right. Take it. Next. So we are biopsying this patient, right?
Yes, the pilot's full lesion is there, sir.
Okay. What biopsy do you want to do for this patient?
Sir,
So what are you going to write on the form
Sir-
to the radiologist? If the, sorry. So in TMH, the radiologist does the biopsy. If you are doing the biopsy on your own, what are you telling yourself?
Yes.
What biopsy will you do?
sir, we can do in this patient 44 PSA with a hard nodule, sir. We have a hard nodule, so we can biopsy the nodule directly, sir. But from the bilateral lobe, sir, we can do few cores
Yes.
from both the lobes. But systematic biopsy,
Yes. So for this patient, in whose the PSA is not in hundreds, and I'm not sure whether he has metastatic
systematic biopsy,
disease.
sir.
Yeah. Systematic biopsy is the
Yes.
probably the most rational answer, right?
Yes, sir.
Anna?
Yes.
Do you want a targeted plus systematic biopsy? Probably not, because there's a lot of disease in this prostate, as we can see from the MRI also, and as we have from our DRE also, right? So systematic 12-core biopsy is probably the most rational answer for this patient. Anna, your patient is not as bad as my patient in the
Yes.
scene that I took, right? Yeah. All right. So we are asking for a systematic biopsy, which means
Biopsy.
6 codes from each
The
lobe.
12 core biopsy. Yes.
12-core biopsy. Perfect. Okay. Next. Can we have the biopsy?
Trust-guided
All right.
biopsy was done, sir. 10 core biopsy was done, sir, in this 5 plus 5
Very
Gleason score 5 plus 5 Gleason grade group 5 and neural invasion is seen in this set too. Tumor volume is approximately 90% of all cores.
All right. So now you have proven that your patient has the highest possible grade
Yes, yes.
prostate cancer. Okay. Now, if this patient's PSA was 4.7, you would have still done the MR and you would have still done the biopsy.
The biopsy, yes, sir.
And then if you have this path report,
Yes,
would you
sir.
want
Metastatic.
something more in the
Sir, I
path
would like
report?
to go. Patho reports, sir, number of cores positive, the percentage of core positives, and
So Swasti, what I'm trying to tell you is,
any other variant.
yes.
Yes,
That variant becomes very important when you see Gleason 9 and 10, but your PSA is only 4, 5, 10,
yes, yes.
right? But your Gleason of 10 is correlating with a PSA of 47,
But-
right? So then you are okay with this report. Okay?
Yes, sir.
Although it is a good practice by every pathologist to mention that those things were not seen in Gleason 10 patients, because Gleason 9, 10 patients can have those components. Okay? Sure. Next. So now
Sir, I would like to-
what do you want to do?
So I would like to do the metastatic workup in this patient, sir. I would
All
like to
right.
go ahead with the PSMA PET CT scan, sir.
All right. Do we have it?
Left iliac bones, metastatic deposits in the left iliac bones are there and multiple.
Okay, can we come to the report?
Any other film, Rajesh? Hey, last.
All right, let's see the impression.
Yes, sir. The bilateral seminal vesicles, few metastatic abnormal pelvic lymph nodes, some multiple skeletal metastases are there, sir. On musculoskeletal comment, sir, multiple predominantly sclerotic lesions involving skull, medial end of right clavicle, spine of left scapula, few dorsal D6, D7, D10, and L4 vertebra, sternum, bilateral,
All right.
few ribs,
Lots of-
and right hip bone. Yes, sir. Multiple. Yes, sir.
Okay. So what does your patient have?
So my patient has a high volume metastatic carcinoma of prostate, sir, adenocarcinoma of prostate, sir.
Perfect. Okay. So now you have the entire information about the disease in your patient.
Yes, sir.
Now what do you want to do for the patient?
So I would like to first counsel the patient with sympathy and empathy about the disease, sir, and then
Very good.
give him the possible all the possible management strategies, sir. And this patient is
Okay. Just one thing
performance
that I
status one.
remembered.
Yes, sir.
When your patient has back pain and all those things in the history and even on your examination, no, it is good to
Yes.
mention on your own that the patient does not have any positive neurological findings.
Yes.
Okay?
Yes, sir.
Okay. So you've counseled your patient, and what is the first treatment thing that you want to do for the patient?
So in this patient, sir, there are spine metastasis, metastasis with tenderness present over the spine, sir. So I would like to start the patient with GnRH antagonist, sir, with ATC and with dexamethasone, sir, and an orthopedic reference for the same.
Okay.
Sir,
See, the back pain, no, is because he has disease in those bones of the back, right?
yes, sir.
I don't think I don't think the history or the examination or the scan has told us anything that the cord is at risk,
Yes, sir. Okay.
right? So if the cord is not at risk, we don't need to give the DEXA and the ortho and the neuro references. We give that when the history tells us that the cord is at risk, or our examination, neurological examination tells us that the cord is at risk.
Yes, sir.
Right? Or for that back pain, somebody has done an MRI for the patient. That is also how prostate cancer gets diagnosed, right? Back pain,
Yes,
you
sir.
do MRI, you see meds, then you do PSA. And if somebody has that MRI and you know that the cord is at risk. So if anything tells you that the cord is at risk, then all those things happen, which I told you in that patient on the stretcher
Yes.
wala slide.
Yes, yes.
Okay. In this particular patient, because there is no impending cord compression, if somebody tells me that I would want to give agonist with
Yes, yes, sir.
bicarbonate, that answer is perfectly acceptable.
Okay.
So any modality of ADT for this patient
Yes.
is fine. Okay.
Yes, sir.
So we want to do androgen deprivation. We'll
Androgen
speak
deprivation.
about all three options that we have:
Yes, sir. Yes, sir.
surgery, agonist,
Surgical,
antagonist.
medical. Yes, yes, sir.
Explain plus minus points of all as we discussed,
Yes, sir.
and then the patient can choose what he wants. Okay. So that is androgen deprivation. What else?
Yes, sir. So androgen deprivation plus, sir, abiraterone acetate, sir, plus prednisolone 5 milligram BD, sir. The OD, once a day.
Okay.
Patient only has hypertension, sir. So,
All right. So abiraterone. What else?
sir, with prednisolone, sir, 5 milligram.
What else?
Once.
Your patient has high volume
Sir,
disease.
yes, sir. So high volume disease plus docetaxel. We can go for a triplet therapy in this patient, sir. Docetaxel plus ADT plus docetaxel plus abiraterone acetate, sir.
Right.
Plus
So
prednisolone.
yeah. So you say that word triplet, right? I don't have to
Yes.
get it out from your mouth.
Yes, sir.
You have to be
Yes.
prepared that if your patient has high volume, you will say that I want to give triplet therapy to this patient. I want to assess whether this patient is fit enough to receive triplet therapy. If yes, then I would want to give this patient triplet therapy in the form of androgen deprivation, those three options, and docetaxel, and a drug. And the drug can be
Yes.
abiraterone.
Along with that, sir, I would like to check for the bone health, sir, DEXA scan and oral examination for the patient, sir. As we might need to start. We will start with calcium supplements and vitamin D supplementation, and patient might require zoledronic acid later on, sir.
Yes. And you will give him calcium vitamin D supplements, is what you said. Okay. What are you doing for his LUTs?
Sir, for
He
LUTs,
came to you with LUTs, right?
yes,
And
sir.
you've explained to him that he has prostate cancer.
Yes, sir. Sir, either we can start with, because he has no history of retention, so we can start with alpha blockers. And if there is no response in 3 to 4 weeks, because we are also giving you androgen deprivation that will cause some shrinkage of the prostate, sir. So his LUTs can improve in 3 to 4 weeks. If it is not responding to it, we can go for a channel TRP later on, sir.
Right. So if somebody has a catheter, no,
Yes, sir.
and wants an orchidectomy, that channel TRP and orchidectomy can be done in the same sitting.
Yes, sir.
Okay.
Yes.
You don't say कि चलो अभी orchidectomy करते हैं फिर 4 हफ्ते बाद देखेंगे catheter निकलता है कि नहीं, and then we'll do the channel TRP. Okay. Did this patient have any family history?
No, sir.
No. Should we still be doing his genetic evaluation?
Yes, sir. In any metastatic cancer of prostate, sir, we will do a genetic testing in this patient, sir.
Yeah. So at least मतलब वो at least mind में रहेगा ना,
Yes, sir.
तो patient से बात करेंगे इस बारे में.
Yes. Yes.
Right? Our routine 71-year-old with all these things may not afford olaparib later on, but an occasional patient may afford olaparib also later on, right?
Yes.
So we have to discuss with the patient. So what will you discuss with the patient?
So I would like
Why
to
do you
discuss
want to do the genetic evaluation? It is going to cost you 20,000 rupees. Why do you
So
want to do the
I
genetic
will
evaluation?
explain the patient that during the course of the treatment, sir, slowly within after 2 to 3 years, he will require further treatment because the patient will not be responding to the same treatment for a long time, very long time after beyond 2 to 3 years. So he might develop a castration-resistant disease. So for that, sir, we will like to go for a second line or third line treatment for the same, and then we will require other modalities like olaparib or something. If there is some genetic mutation, there are drugs that are available for patients who respond to those drugs in case of presence of genetic mutation. So
Exactly. So if you
yes,
feel
sir.
that this family and patient will be able to afford olaparib 2-3 years later down the line, no, only then there is any point of even doing the genetic evaluation for the patient. Okay. Otherwise, there is really nothing to do for this particular patient with genetic evaluation if the family is a poor family.
Sir.
Okay. All right.
Sir, do we do genetic testing in our setting here, sir? At
in
Tata
our
or
setting,
मतलब
no,
सर
yaar,
हमारे यहाँ जैसे
we do have a genetic department, but I don't think we do in-house testing of all the genes that I mentioned. So BRCA would be checked because our breast cancer patients are also checked for that. But like a proper prostate cancer panel is I don't think it is done with us. It is also sent somewhere.
so at Tata and all the other centers we offer genetic testing to all metastatic cancer patients, sir.
So we have a private OPD and a general OPD. In our private OPD, we do speak to our patients. In our general OPD, we would probably not speak to our patients about genetic testing unless that patient is 50, 55, in whom I actually want to check if any other family member has it. And instead of doing somatic testing for the patient, because even if it comes positive, he won't get olaparib because he can't take it. But if his germline comes positive, I would want to check his brothers for prostate cancer. So I might just do his germline testing. See, if germline is negative, then the family does not have it, mostly, right? The somatic may
Yes.
still be positive, right? But even
Yes.
if the somatic is positive, he can't afford olaparib. And every genetic test, germline and somatic, comes at a cost, right? So you probably just see कि क्या आज किस में check करना है. Basically, it depends कि क्यों check कर रहे हो. Patient के लिए check कर रहे हो, उसको olaparib मिलेगा तो somatic test करो.
Yes, sir.
ये चेक करना चाह रहे हो कि फैमिली में किसी को स्क्रीन करना है क्या क्योंकि पेशेंट यंग है और स्ट्रॉन्ग फैमिली हिस्ट्री है तो जर्म लाइन चेक करो. ठीक है.
Yes.
Sir, I think that is okay for a short case, no?
Yeah, excellent. It was, the streamline was absolutely clear, and I'm sure that, in exam also, everyone will have a clear thought that
Yes,
how
I
to
just want
answer
you all
it.
to clear. See, everything that we are doing is with some reason. Every test that we prescribe is
Correct.
with some. So if you know the reason, you will not forget the test and why you are doing it. And then what you should be telling your examiner why you want the test. Okay. There's just one question in the pan. Somebody's written, should we use G8 score or mini ECOG score for 70-year-old patient with all cancer with CA prostate? It is a good idea to use those calculators, that the G8 score and all, for calculating the ECOG status and the frailty and all those things. All that now is usually done by our medical oncologists because they want to check whether the patient is fit for those systemic therapies that they want to give, the chemotherapy and the abiraterone and the enzalutamide. Okay, androgen deprivation therapy, mostly all patients are fit. So we as surgeons usually don't use these scores much. For us, the general physical assessment as the patient walks in is enough to tell us whether androgen deprivation करना है नहीं करना है, orchidectomy patient tolerate कर पाएगा कि नहीं, right? But whether this patient's health is going to go down with chemotherapy, with triplet and all, is more of a medical oncology, of more of a physician domain. So I do not happen to use this G8 score too much. Okay. As surgeons, you would probably want to use these scores when you're doing major surgeries in old patients. Like if you're doing a cystectomy in an old 75-year-old patient, you would want to see the G8 score and those other Charlson comorbidity index scores and all, just to see whether this patient can even tolerate the therapy that you're planning for the patient. Okay.
Yeah. Okay.
Regarding
That,
docetaxel re-challenge, sir.
Yes. So see, docetaxel re-challenge means we are at CRPC. Means you have given it already in HSPC. Then something has happened, patient has progressed, and you want to again give docetaxel. So the medical oncologists usually say that if you are using chemotherapy, then if it has failed, you should use some drug, and then you can probably use chemotherapy again. Okay. So between two chemotherapies, which can be either docetaxel or cabazitaxel, or docetaxel with re-challenge docetaxel, there has to be a drug window in between. Okay. So that those cells probably again become responsive to chemotherapy. Okay. in which patients is it used? Does it work? I don't have answers to it because I probably a medical oncologist is somebody better to answer this. But that is like CRPC setting, which I don't think your exam will reach to. If it does, then you've probably just aced your HSPC answers, and that is why you're answering that, right? But this question does not have one particular guideline based yes or no answer. That is why I don't know it. It's a more of a clinic based answer. So that is why probably a medical oncologist would know the answer.
Right. Okay, Ganesh bhai, you want to ask anything? Gite, Pankaj Maheshwari ji, genetics के बारे में अगर if you have got any more information.
Nice, sir. I think it has gone very well.
Yeah. Okay. Fine. Then I think that another short case we just finish it. Brijesh,
Yes, sir.
now I want first Hamid, I want you to answer now. Hamid, and who else is there?
Dr. Aisha.
Yeah, Aisha is there.
I think they have not joined, sir.
Okay. Then Swastik, you only answer. Yes, you only read very fast.
So 76-year male patient presented with complaints of staining during maturation, increased frequency in dysuria since 3 months, sir. So I would
Okay.
like to elaborate the symptoms, sir. And then patient is apparently
Just
symptomatic
read
3
it.
months. Yes, sir. 3 months back when he developed.
Just positive. Brijesh,
Yes,
what
sir.
are the
Positive,
positive
sir.
things?
Yes, sir.
So again, the same DRE finding. Huh? So we have somebody who's 71 who has LUTS, who has a hard prostate.
The rectal mucosa is fixed in this patient, and rectum is empty, no blood.
Achha, so it's rectal fixed. So you know it is T4.
Yes, sir. T4 disease. Yes, sir.
Okay. Okay. Now come to blood tests.
Yes.
So the PSA is similar.
Case is 41.
The creat is also a little high.
1.3. Yes, sir.
Okay. Okay. What next?
So urine routine microscopy, USG abdomen pelvis, and yes, sir. And then we can go for biopsy, sir. Systematic.
इधर तेरे को MRI क्यों नहीं करना है स्वस्तिक?
नहीं.
This PSA is 41 and
Sir,
is small, lesser than the 47 PSA of the first patient. क्यों नहीं करना है?
Sir, DRE finding, sir, seems to be the mass seems to be involving the rectum, sir.
Exactly.
So,
Right.
yes,
Why did you do that MRI in your first patient? Only one
because
reason.
the
T staging. Because you did not know कि METS आएगा कि नहीं आएगा.
yes,
इधर आपको T staging पता चल गया है कि ये तो T4 है. एटलीस्ट सर्जरी के लिए तो नहीं आएगा. नॉन मेटास्टैटिक हुआ तो भी शायद रेडिएशन का या कुछ सोच सकते हैं. सर्जरी के लिए तो नहीं आएगा. Right. So it is a very rational thing to say कि I don't want to do MRI in this patient. It is not going to add anything right now. Okay.
yes. We'll go for biopsy, sir. Yes, biopsy.
All right. The MRI has been done, but ठीक है. So the biopsy is again Gleason
5 plus
10.
5, sir. 10. 60% of the core involved, 50%. Yes, sir. 5 plus 5 is 10, sir. High score.
Yeah, so again, these things know of how much percentage of cores are involved
Yes, sir.
is immaterial when you have Gleason 9 and 10 and 8
9,
disease.
10.
Right?
Yes, sir.
How much percentage of cores, how many cores are involved? This all
In the low grade.
yeah, in
Yes,
low
sir.
and your favorable intermediate, because
Yes,
then you want to decide कुछ करना है कि नहीं करना है, right?
Yes, sir.
So
Yes, sir.
when you have Gleason 8, 9, 10, everything else written in the report is immaterial. ठीक है?
On ISC, sir, tumor express PSA and AMAC are diffusely with they are negative for CK7,
Okay.
CK20.
ठीक है.
Occasional expression CE. Okay.
Hmm.
So I would like to
Okay.
do a metastatic workup, sir, in this patient, sir. PSA PET scan.
So
Hmm.
my question to you, Swastik, is now you know already it is involving rectum. You
Yes, sir.
know it is already advanced stage 4. Why you want to do metastatic workup? How it is going to help you?
So we need to find out whether there is a metastatic disease, how much is the volume of the, whether it is a low volume or a high volume metastatic disease, sir, and whether we will need to proceed with
No, when
triplet
the
therapy or
rectum is involved, what type of disease it is?
sir T4 disease, sir, for local staging, sir, T4 disease.
Okay. So give the reason, sir, why you want to see high volume, low volume, but here it is already the other organ is involved. Huh?
Yes, sir. So, sir, this patient will not be for local management, sir. Local management, surgical management or radical prostatectomy के लिए नहीं होगा, sir, this patient. But we will need to rule out the metastasis and then the volume of the metastasis, that is a low volume or a high volume disease. So, for the further planning and management of the management of the disease, sir, further plan management.
Yes.
Okay, what else?
So,
What is another defense answer that you can give to what sir is asking? See, basically, this patient is getting androgen deprivation.
depression,
So
yes,
we'll
sir.
probably
So,
get
response to
something.
the treatment, the follow up and response to the treatment, sir.
So you want a baseline scan
Yes,
to
sir.
know कि जो 3 months पे या 6 months पे scan करेंगे उसमें जो दिख रहा है, how does it compare to the baseline scan, है ना?
Yes,
So that is one more defense to what sir is asking, that you would want a baseline scan. कितने bones में mets है, क्या है? So you can judge response कितना है. Okay?
yes, sir.
Okay. So he has some PSMA avid, some nodules, okay, which are metastatic.
Periprostatic and perirectal nodules likely metastatic, sir.
Okay. So this patient does not have bone mets.
Bone mets, sir. Yes, sir. So the
Okay.
patient is not having bone mets, so it is a low volume metastatic disease, sir.
Yes. So these are all nodes, right?
Yes, sir.
But
Only
these are
nodes,
all
yes.
non-regional nodes. So he has
Not,
M1A disease,
yes, sir.
right? So this is low
Yes, sir.
volume metastatic hormone sensitive prostate
Low
cancer.
volume metastatic.
Perfect. Okay. Sure. What next?
So in this patient, sir, after counseling and also, I would like to go with ADT with abiraterone acetate plus prednisone plus later on radiotherapy to the prostate, sir. Before that, if the patient is having no response to LUTs with alpha blockers or after androgen deprivation, I would also like to perform a channel TRP, sir.
Okay.
So ADT plus abiraterone acetate plus local therapy, sir. Local therapy may be a radiotherapy or channel TRP, sir.
Yes. So local therapy we'll look at later. At that
Yes,
time
sir.
also, if we want to plan local therapy, we would again want to confirm whether the rectum is free or not. Because giving radiation therapy to a prostate which is stuck to the rectum can lead to rectourethral fistulae also.
Sir.
You know? So not all patients with low volume disease should get RT to the prostate. If it is going to worsen their condition, they should not get RT to the prostate. Okay? And then you will do all your routine calcium, vitamin D, do your DEXA scan, decide about zoledronic acid, right? Talk to the
Yes, sir.
patient about genetic testing. And that, right? It is very systematic what you need to do for a metastatic prostate cancer patient.
Yes, sir.
Take it. All right, should be okay. Sir, this should be okay.
I think we have done
I
completed.
think all
I think
points
both the
covered.
cases were different.
All the
Ganesh
points.
bhai, your comments.
No, sir, all the points are covered, so we are okay. I think it is enough for a good understanding of everybody.
Yeah. Amandeep, thank you very much for
Thank you, sir.
It was
covering up
very
the whole
nice and
subject.
detailed presentation.
Thank you, sir.
Yes.
Thank you so much, sir. Thank you.
And
Thank you.
I think he answered very well. Correct, Ganesh?
Yes, Swastik did a good job.
Yeah,
Well
yeah,
done.
he answered very well.
Yes.
Yes.
So
Okay.
next time क्या है अभी sir?
अभी स्वस्तिक क्या है नेक्स्ट टाइम? I think CA bladder. We are starting with CA bladder. So
Okay.
tomorrow I will discuss in our group how to go about. Like today, we will discuss about okay, how to go about. Huh?
ठीक है.
Okay. Good
Okay.
night to everyone.
Okay.
Good night.
Bye, sir. Good
Amandeep,
night.
maybe if
Thank
you
you.
have time, थोड़ा देर next time join कर सकता है.
Yes, yes, sir. Definitely.
Amandeep, yes.
Yes, sir.
Hmm?
Yes, yes,
We
definitely,
will
sir.
now send you the link whenever
Okay.
there is a malignancy.
Okay, sir.
Okay.
Sure.
Thank
Thank
you.
you. Bye, sir. Thank you
Good
so much.
night.
Good
Bye,
night.
sir.
Good night.